about 10 minutes for discussion. If anybody has comments, please get up and share your thoughts. But, well, first question, Brad, why didn't you just put a bulldog on the mammary? I think everybody here was asking the same question.
I don't go over there for fear of injuring. So
for fear of injury, look at the operation you're doing. You're doing an incredibly complex operation.
I never go over to Lehman LAD. I just go cold and let it fibrillate or do what I did.
Well, if you injured the mammary, though, that'd be a lot less of a problem than if you injured the LAD. I mean the left main. But anyway, now there's a whole nother session on the Ross, right? So we're going to devoid that from the conversation. So, Joe, if there's a lot of people on this panel that are right at your crossover point of the bio versus mechanical valve. What would you take into account when you make that decision, and would you go with your own recommendations as to that crossover point?
We're essentially not putting, well, in the practice of some of us, we're not putting in mechanical aortic valves. So it's just the limit of when you'll stop Ross and put in bioprosthetic valves. Yeah. You want to know the number.
Well, no. Well, what I'm saying is there are patients that have a pulmonary valve that's not appropriate for a Ross. Let's say that's you, unfortunately. Would you do a mechanical? But you just said nobody does a mechanical anymore. But obviously, you said that in a great majority of patients that are younger, it's better.
The data are one thing, and then our clinical practice is another. So, you know, I've asked the exact same question of people with rather extensive Ross experiences, you know, Ishmael, and I've asked Vaughn, and it's actually relatively rare that they've run into pulmonic valves. I don't want to speak on their behalf, but relatively rare that they've run into pulmonic valves that can't be used. So it's a very rare occurrence, I think, where you're in a younger patient that you can't do a Ross. You know, obviously there are some constraints, but we're using them in we're doing the operation in some strange scenarios, again, it's just, to me, it's a cutoff of when the bioprosthetic valve kicks in. And you know, I showed you 65 with LAD disease, and you know, I think there's people in the audience who have done it in 70-year-olds.
It still only represents 2% of AVRs in the country.
Yeah, or less.
Or less. Dr. David?
I'd like the audience to ask more questions. You heard some quite spectacular presentations. I'm going to start with a bow. It doesn't matter how deep you go into the intervallar fibrous body, and as we split the entire fibrous body, you do not increase the size of the outflow tract. So because your technique or your patch allow you to put a valve 29 as opposed to 21, the benefit is no more than putting a 23. Because if you take a look at and CT scan doesn't lie, I think Brad showed several images of it like that. The problem is the outflow tract. It's not going to increase. The intertragonal distance represents approximately half the outflow tract. You're not increasing the intertragonal distance. What you're doing, you're putting a patch above the intervallar fibrous body and implanting a much larger valve. But larger the valve, I'm going to submit to you, the stent is much larger as well. So you lose significant area attached to the septum. So although it's a 29 valve, the outflow tract remains 21, 22.
So that's...
I don't know if people, the audience understood my point.
Yeah, that's a very common question, Tirone, and many people ask the same question. So when a patient, when they're 50, 60, 70 or younger, they come to me with aortic valve stenosis, the LVOT is normal. So patient come to me with aortic aneurysm 23, LVOT is 23, that's normal for him. And we put a 23 valve in, the valve opening 16 millimeter. The bottleneck is the valve. It's not LVOT. And we follow those patients. We upsize the valve. We found out with the 2/3 of female, the LVOT diameter was 20 before surgery, was 22 after surgery on TTE. We did not enlarge the LVOT, as you mentioned. That's correct. But why the LVOT increased? Because the LVH regression. The mean gradient before surgery across the LVOT was 2. After surgery is 2. So those different population, I think the patient with aortic valve stenosis is the valve problem. When they are 20 years old, when they run marathon, the valve is normal, LVOT is normal. Once the valve is calcified, we replace the valve, put the valve on top of the LVOT. LVOT is normal, and the valve size matches the LVOT. So there's no bottleneck. That's how this procedure works. We follow all the patients, their gradient is really low. Cross
Well,
LVOT
I
and
don't-
cross the valve.
I don't dispute that, and I'm among those surgeons who do believe that patient prosthesis mismatch is a problem. So you should optimize the size of the valve to the size of the patient and the size of physical activity. But if you take a look at the results in the end, 10, 20 years later, patient prosthesis mismatch, unless it's severe, has no effect at all, as you know. We in Toronto have an affiliation with the Hospital for Sick Kids, and we do see some true aortic stenosis with outflow tract of 12, 14 millimeter. There is no way that enlarging the posterior part of the annulus is going to solve that problem. The only operation to solve the problem on congenital aortic stenosis with outflow tract less than 20 or 18 millimeter is to cut the septum in half. In other words, you have to split the other side, the muscular septum. Unfortunately, you transect the first septal perforator, you're going to give the patient a septal infarct, but you are caught between the devil and the deep blue seas. I think there's a limitation how much you can enlarge the annulus on the intervallar fibrous body, unless it's a double valve replacement, and then you can cut the whole intervallar fibrous trigon. You can put a valve of any size.
Yeah, I think that's a different disease. That's LVOT stenosis, and that's in congenital patients, right? There are babies that have LVOT, hypoplastic LVOT. That does need LVOT opened up with conal. But LVOT in adults, most times is normal.
Let me make a comment about the conal. Never, ever cut the septum, okay? Not the true septum. Go into the conus, okay? Go into the conus in the LV outflow tract. I mean, towards the RV outflow tract, okay? If you cut into the septum towards the apex, yes, you'll cause injury and you'll cause heart block, a whole host of other things, and that patient will probably die of heart failure. Make a turn to the left. But I do agree, in the congenital patients, yes, absolutely. That's an anterior incision. The problem that I've seen is the Ross conal. When you do the Ross conal, which we do actually fairly frequently, yes, you have a very nice autograft in that outflow tract, but often people make the mistake of putting in a Dacron patch to cover that incision into the ventricle. After 10 years, that Dacron is calcium. It distorts the autograft, and then you have an injury. Now you have two-valve disease that is not very well managed. So if you're going to do the Ross conal, which is actually becoming it's a really good operation for most of these kids. Use bovine pericardium, use autologous pericardium, use something that isn't going to become a rock and distort the flow dynamics underneath that autograft.
David, you want to have a comment?
I learned so much. It might be my first aortic session in like 10 years, but I learned a lot today. Going down the line, Brad, thank you for proving my point this morning. All this valve nonsense, la land. Please don't do complex procedures for planning the future valve operation. Gilbert, I'll look forward to your talk next, but I'm not drinking that Kool-Aid. That didn't look good, did it? Bo, are you kidding me? If you have a calcified coronary osteo, I get it. Then I get it, because you can't reimplant coronaries. And what patients get this size 31 valve or 29 valve? I mean, we can't recreate everything. You can tell me the 23 valve or a 25 valve. Now a 25 is no good. I mean, I'll tell you, go to a aortic meeting. 10 years ago, it was criminal to put a 19 or a 21, and now it's criminal to put a 23 or a 25 in. Pretty soon, the company's going to have to make a size 37 valve or something. and it will have, by the way, it will have another name procedure. Someone will do it 20 times and publish it in an open journal. I mean, come on. You do not need a 31 millimeter or 29 millimeter valve in most patients. We can't recreate history. If there was a mortality risk putting a size 25 valve in patients or a size 27 valve, we would know it. So maybe a little, if you want to enlarge the root, that's great, but give us a good reason to put a patient through a bigger operation. I mean, I really mean it. I think that looks a little bit tricky. And then we talk about the STS mortality, and you wonder why mortality rates get higher, like when you take out TAVR valves. So I don't know. And then Ed, correct me if I'm wrong, your series, you said it. You had a little higher than expected mortality, 7.7, I think, was 7.7. But the patients that survived had lower gradients. It takes a long time to make up for a few extra % mortality in terms of the risk of a gradient. I think it gets back to what we always say on the mitral side. Keep it simple. You got to survive the day of surgery to get any benefit about a hypothetical valve, and my valve is a size 29, how big's your valve? You better survive the day of surgery first. I don't know. I'm just a simple surgeon, but if you're going to do all that, why not just put stentless valves in, which is what we do. I just call Ishmael. If we're concerned at all about PPM, unless the coronary buttons aren't calcified, we just do a stentless valve. Doesn't that solve the problem and also address what Tyrone's saying?
I give a quick answer. Number one, the optimal mortality is now 7.7, 196 cases with one death.
That was for Ed.
Yeah.
Ed showed his paper. I wrote it down.
Yeah. So for the AVR, the enlargement is very teachable. Mortality is very low. One patient death of the multi-valve radiation cavity times 3. So it's simple AVR with enlargement. We had 0 death. All my fellow can do it. It's a very teachable operation. That's number one. Number two, I think we have been fooled by this labeling. 29 valve sounds huge, but if you measure the opening, it's 23 millimeters. That's much your original. Dr. Adams, you do mitral valve repair. What's your ultimate goal? 0 MR, right? Patient, because a normal mitral valve doesn't leak. We place the valve, I put the valve size half of the patient native annular size. We call it a day. We think it's a good operation.
And what I'm trying to, I'll ask you just one simple question because I obviously shouldn't even be up here. If you have a size 25 annulus and you weigh 68 kilograms, are you going to do a root enlargement to put a 29 in, or I don't know, or maybe you're going to start putting mitral valves upside down or something? I have no idea. I mean, can't you just put a 25 valve in someone that weighs 70 kilograms and not be worried about their long-term mortality? But I bet you right now, if they go to your hospital and you're in there, you're going to take a resonant through your procedure and add another one to the end, and that's what I don't like. I don't mind if you tell me which patients need it and that you really think there's going to be a benefit, but I really don't like when we just fit patients into procedures, particularly if we have our name on them. I think we got to be very thoughtful about which patients we're willing to even take 0.25% risk. And don't tell me there's no mortality. Do enough of any operation and there's mortality. So you just got to be thoughtful. And Ed, I'll just ask you again about your procedure. I get it, it was a neat procedure, but there was a high mortality rate.
It was high, David, you're right, but we did a lot of concomitant operations, and 30% of the cases were redos. So, obviously we could always do better, but your point is well taken.
We're going to give the final comment too. I just want to add, I want you to add one thing. Your series of Rosses is 200 and X patients, right? Have you done more than 200 mechanical?
That's a pioneer. When it started in the 90s.
Yeah, have you done more than 200 mechanical valves or 200 biologic valves in the aortic position? And why so few Rosses compared to that? You've probably done the thousands.
Highly selected cases.
That's what I want to know.
Oh, but they are.
Because everybody on the panel here does a Ross in every single patient. And everybody in the audience, too.
Last, when it was Monday or Tuesday this week, triage case, 45-year-old, Vivra was on call, said, Tirone, there is a patient that needs a Ross procedure, 45-year-old, in the CCU, in heart failure, ejection fraction 18%. And then I took a look at his CAT scan. The whole septum is calcified. I'm not going to do a Ross on that patient. As a matter of fact, I almost killed him by doing conventional aortic valve replacement. I had to cut half the septum out, put a huge patch in the septum to keep the septum together. Anyhow, I'll finish with this one. Bo, we didn't invite Maral and Dave Adams invite you here to crucify you. That's not the intention. The intention, the intention is to be honest and try to find the rationale. I don't know if you guys remember when in high school, your teachers crucified with the geometry, you had to go home and calculate the area, the height of this thing in geometry. That was taught to you not to throw away, not to learn and go home and forget about. Those stuff was being taught for hundreds of years, how to educate us. If you have a circle, whatever size the circle is, if you lose 1 millimeter in the center of the circle, you lose 1 millimeter square. If you lose 1 millimeter in the periphery of the circle, it's not 1 millimeter square you lose of area. You are losing 1 millimeter times diameter times r square. It's an incredible loss of area. So putting a 29 valve, there's no guarantee that it's better than 25. And Dave Adams is right. Because the stent is not 3 millimeter, it's 4, 5. So you are losing the periphery, 4 millimeter. 4 millimeter times 29 times radius square. Your loss is much greater. So you don't gain effective orifice. There's a physical limitation on a bigger valve. Take a look at the stent. They're bigger. No human being needs more than 27 to be quite honest.
Okay, that's the final
On that
comment.
note.
Thank you so much. Great discussion. Thank you to all of the presenters.
I think you guys are supposed
Great
to say.
discussion. Thank you, Bob.
Your names
Your talk
are on
was
it.
great. Okay.